have allowed Dr. Ria Daniel to record. Yes,
Yes, sir.
But
Yes,
do
sir.
you find her
Good
on the
evening, sir.
screen
Yes,
somewhere?
sir. Yes, sir.
Yeah, Ria, I am not able to see you. I'm not able to see you, Ria. Hello.
sir,
Hello.
Dr. Ria has started the recording.
Yeah, just hold on till we start. We will give you a green signal. Then only you start, please.
No, sir,
Yeah.
the entire presentation will be recorded, sir.
Exactly. Yes.
Yes.
Yeah.
ಹೇಳ್ತೀನಿ ವೆನ್ಸ್ಡೇ ಬರುತ್ತೆ ಫೋನ್ ಮಾಡ್ತೀನಿ ಫೋನ್ ಮಾಡ್ತೀನಿ ಈಗ ಲ್ಯಾಬ್ ಹೋಗ್ಬೇಕು ಸೋಮವಾರ
Yeah, Ria, you are on the line. You can see the screen. Yeah, I'm unable to see you actually on the screen. Yeah, that's why I just asked. Okay. Thank you. Bye. Rajiv, good evening.
Good evening, sir.
How are you?
Are you able to hear me? All good, sir. All good.
Yeah. Wonderful. We will start in another few minutes. Yeah, you believe?
Yes, sir.
Yeah. Hi. You believe?
Dr. Pradeep is here. Hello, sir.
Yeah. That's wonderful. So you're on the line. Great. We'll start in short time.
Thank you.
Yeah. Vivesh?
Hi Carla, how are you?
Yes, fine.
Hello.
Just fine. I'm able to see you. Vivesh? Keep your video on. Yeah. Dr. Nagmani? Hello? Yeah. Chaudhary, good evening.
Yeah, thank you.
Yeah.
Hi.
Nagmani, good evening. How are you?
Good, thank you.
Hi.
So good. Nice to see you from US. Yeah.
Yeah.
Very good. Yeah. I hope you should join similarly in all the occasions. Yeah.
Thank you. Happy
Welcome.
Independence Day.
Same to you all. Yeah.
And so we also have Dr. Ronan Naidu on. He's
Yeah.
one of the top periodontists in Durban.
So nice. Yeah, Rohan, welcome. God bless you. Yeah.
And Mukesh, if you remember him, one of my classmates.
Yeah, where's Mukesh? Where's he?
There's he there as well. Mukesh is on.
I can't see him on the screen. Yeah.
The pictures are off.
Hello, Mukesh.
And
I'm ready to-
Anish Maharaj is also on.
Yeah, Anish. Yeah, wonderful. Nice to see you all. Yeah. So shall we start the program?
Yes, sir. Please, sir.
Yeah, Smita, you are there?
No, madam is not there, sir. Still now not there.
Why? What's the problem? I should be on the line. I'll just check. Hello, Smita. Yake? You take this number, you can find out. I'll give you the number. Just hold on. Yeah, note down, take a piece of pen and paper. Yeah. 412-6495 772. 772. Okay, and the password is 513478. 478. Yeah, log this. Okay. So in the meantime, I'll just start the ball rolling. Good evening, ladies and gentlemen. Can you hear me all?
Yes, sir.
Yeah.
Yes.
Yeah. Good evening, ladies and gentlemen. On the eve of 74th Independence Day of India, I extend a very warm welcome and a happy Independence Day to all Indians and friends from abroad and India. We India are highly privileged to inform you that our group, Dawn of Dinosaurs, is a closed international academic group of nearly 150 members. We are interacting for the last 2 years, and now this is the 3rd year. To mark the occasion, we have been fielding some virtual meetings over the last 2 or 3 occasions. This being the 3rd occasion where we are interacting. The concept of our study group is to learn from each other. We at the Dawn of Dinosaurs have come out in our field of medicine and dentistry in respective places, wherever you are in the world. And we have quest for learning. Our group has people from almost all over the world, be it from Kuwait, Iran, UAE, Malaysia, India, Singapore, South Africa, USA, New Zealand, Australia, and United Kingdoms. Today, our focus is on periodontal diseases and COVID-19. Incidentally, these two are the greatest diseases of the mankind which we are having. In fact, periodontal diseases have afflicted every individual. No man is free from it and no race is free from it. It's something like a scourge upon mankind. Incidentally, COVID-19 has also been a great epidemic which has been taking a toll all over the world. Incidentally, we have still no remedy. We have no still vaccine for that to solve the problem. In fact, our own past president of Pranab Mukherjee, our greatest cricket batsman, Chetan Sharma, and then the greatest singer of India, S.P. Balasubramaniam, they are also suffering from this unfortunate epidemic. And we have a struggle to this extent that we have been certainly winning over to a larger extent with only about 1.9% of death rate in such a big population. And incidentally, we have a good number of people who are ailing from it after United States and Brazil. Incidentally, Carla Prontes is from Brazil, and she must be knowing the situation in Brazil as well. So ladies and gentlemen, so I will start the meeting today with handing over the information to Eubulus, who is going to introduce Carla Pontes to us. Eubulus?
Thank you, sir. Thank you so much. We really appreciate it. First and foremost, we want to, I think all of us here, either Manipal or some of the other, we have been under your influence and under your patronage, and you have been a great teacher to us. As your name says, a guru. And even now, in your old age, you still are there every day. You test our thinking, our gray matter with all these wonderful quizzes that you give us. And we appreciate that and all that you've done for us, first and foremost. And also to all our friends out there all over the world we haven't seen for years and decades, I think. It's nice to know that we're all in together. I just want to introduce you to Carla. Carla is, I've got to know her recently over the last couple of years. She's an amazing researcher and a dentist. So Carla is from Brazil. She's a Brazilian dentist and has with an MSc in periodontology from University of Sao Paulo. And she also has a PhD from University of Copenhagen, where she was an assistant professor before relocating to South Africa. She now lives in Cape Town. She works as an independent dental researcher and scientific writer, having published in international journals. And her main passion is turning scientific facts into biological stories. You see, she's very good at telling stories. In her free time, she's an amateur artist, loves animals and adventure in nature with her family. So without ado, sir, I would like to introduce you and give it over to Carla. Thank you, Carla, for joining us.
Yeah,
Thank
Dr.
you.
Carla, please join. Yeah.
Okay, thank you. Please bear with me. This is my first webinar. I've been living in my own cave. So I had my son, who's 12, to help me yesterday with the technicalities of it. So I'm hoping that it's gonna work. Please let me know. You should soon start seeing my
Yes, ma'am. Your
slides.
screen is
Yeah.
visible. Your screen
Yeah.
is visible.
Good.
Good start. So thank you everyone for this opportunity. I feel very honored to be able to participate in this group and to be invited to give this short talk. I had a break from dentistry when I moved to South Africa, and I missed it badly. I came back, and now I feel like I'm slowly getting back to it again. So without further delays, I want to present you the topic. We're going to discuss how the potential connections between periodontitis, inflammation, and IL-6 levels, and how it can potentially contribute to COVID-19 lung complications. And this talk today is based on a review study freshly out of the oven that I had the privilege to publish with Dr. Shervin Mulayam from Los Angeles. And it's still published ahead of print. It will be available in the October issue of the Journal of California Dental Association, but you can find it online already, the full article on this link, www.mouthcovid.com. So short overview, we're going to introduce the topic, then talk about IL-6 and periodontitis, lung diseases and periodontitis, what is the link, and then what's the role for IL-6 in COVID-19, and lastly, we're going to look at the potential biological mechanisms behind this association. So, we all know how dental professionals have suffered the impact of COVID-19, which is directly related to the oral cavity being a transmission route and one of the entry points of the virus to the body. Also because salivary glands can potentially function as reservoirs for the virus. Furthermore, saliva is highly infective, and that affects dentists directly because of the nature of dental treatments. And of course, this leads to serious occupational health issues in terms of infection control. And then dentists all over the world are definitely suffering from financial limitations, the cost of PPE, a decline in patient numbers. So dentists, it's challenging times for our profession, and we might need to consider focusing more and more on a general approach, as dentistry is part of essential healthcare. So let's look a bit on the relationship between IL-6 and periodontitis. So the inflammatory process in periodontitis that lead to destruction of the periodontal tissues, the innate and adaptive immune system participate and respond to microorganisms in the biofilm. As a result, several cytokines are produced from different cells, and cytokines are soluble proteins that attach to cell surfaces through specific receptors. So when they link to the receptors, they regulate cell function and cell interactions. So in periodontitis, cytokines cause cascades that affect the intracellular environment, and then as a consequence, they regulate the host response. In general, the most studied cytokines are the pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin beta, and interleukin 6. So interleukin 6, or IL-6, is a well-known pro-inflammatory cytokine. It's produced by a variety of cells in the gingival tissues. And in periodontitis, it is crucial because it regulates the response to infection, to injury, and it also regulates alveolar bone destruction. So there are a lot of studies that talk about the importance of IL-6 to periodontitis. So we have a lot of genetic studies, and they show us that single nucleotide polymorphisms in the IL-6 gene can increase susceptibility to. Then we have in vitro studies that show that IL-6 can be produced by a variety of gingival and blood cells. And in fact, peripheral blood cells from periodontitis patients, when stimulated with periodontal pathogens, they produce higher levels of IL-6 when compared to peripheral blood cells from periodontally healthy patients. Furthermore, we have several studies showing that in periodontitis, IL-6 levels are upregulated in gingival tissues, in gingival curvicular fluid, possibly in saliva, and in serum. And other studies have shown that periodontal treatment is able to decrease local and circulating levels of IL-6, both in healthy patients and in patients who present systemic conditions. And we also have a few studies, not so many, pointing that other oral conditions can also increase IL-6 levels. That includes pulpitis, periapical lesions, and oral squamous cell carcinoma. But we have less studies on those conditions. So now let's look at the link between lung diseases and periodontitis, what the literature tells us. The first disease that was linked to periodontitis, or one of the first, was chronic obstructive pulmonary disease, or COPD. So this is a highly prevalent inflammatory condition, and in the US alone, it affects 24 million Americans, being one of the leading causes of death in the country, actually. So it's characterized by compromised pulmonary function, limited airflow, and breathing problems. So observational studies have linked COPD to periodontitis, and this association was supported by a meta-analysis from 2012. In total, that meta-analysis included over 4,000 patients with COPD from 14 different studies, and the authors concluded that there is a robust association between periodontitis and COPD with odds ratio of a little bit above 2. And the authors concluded that periodontitis is indeed an independent risk factor for COPD. And then more recent data from COPD studies show higher prevalence of periodontitis in patients who require hospitalization. And other studies have shown that fewer remaining teeth, higher loss of attachment, and higher levels of inflammatory mediators were reported in COPD patients. So next, lung disease that has been linked to periodontitis is pneumonia. So pneumonia is the infection of the pulmonary parenchyma. It can be caused by bacteria and by viruses. So it has high mortality rates globally, and it's often linked to impaired immune system. It can be divided into community-acquired or hospital pneumonia. So a systematic review from 2003 found a significant association between nosocomial pneumonia or hospital pneumonia and poor oral hygiene. Then another systematic review from 2006 found good evidence to support a link between antimicrobial oral hygiene interventions and decreased incidence of pneumonia in nursing home patients. Then several randomized clinical trials published since 2010 further confirm the evidence on the impact of poor oral hygiene and periodontitis in the incidence of pneumonia in adults. So some results from a very interesting randomized clinical trial. So this is actually very interesting. They took two groups of ICU patients and they offered complete dental treatment for half of the ICU patients. They eliminated all hidden sources of infection in the mouth. The other half just received regular oral hygiene care given by ICU nurses. And the results were very interesting. So there was a dramatic reduction in the incidence of respiratory infections and pneumonia in the group that received full dental treatment, elimination of all inflammation sources. So very interesting. And then we have some studies that evaluated lung function, mostly in systemically healthy patients with periodontitis. And some studies found there is a significant association between periodontal status and missing teeth, and then lung function, airflow limitation, and reduced lung volume. Then some other studies indicate that periodontal treatment is able to improve lung function. So now let's jump to IL-6 and its role for viral infections and COVID-19. So we all know that the infection in 80% of the infected people, there are either no symptoms or self-limiting mild to moderate symptoms, which most of the cases are cold-like symptoms. But in 20% of the infected, they develop severe symptoms that require hospitalization. And in 5%, those symptoms progress to requiring ICU care and mechanical ventilation. So overall, mortality rates are about 0.25 to 3%, but in higher risk groups, which include age above 70 years, respiratory disease, diabetes, cardiovascular disease, and cancer, mortality rates can go up to 60.5%. So IL-6 is crucial for viral infections and together with other inflammatory mediators such as IL-1 beta and TNF-alpha. So studies suggest that in COVID-19 infection, there's a massive activation of dendritic cells, macrophages, and monocytes. And they produce a high levels of inflammatory mediators, including IL-6. And then IL-6 binds to target cells in the body, increasing cytokine production. So that perpetuates inflammation, which could be in lung tissues and in other organs. So studies are gathering information that suggests that high IL-6 levels can worsen alveolar capillary blood gas exchange in the lungs and reduce oxygen diffusion, which gives rise to complications such as fibrosis and lung failure. So the study that actually inspired our review study is a German study where they had 40 hospitalized COVID-19 patients, from which 32.5% required mechanical ventilation. So they measured IL-6 when they were admitted to hospital, and they measured IL-6 again just before they require mechanical ventilation, if they did. And the results were striking. So high IL-6 levels was a strong predictor for respiratory failure. So much so that patients that had levels above 80 picograms per milliliter had a 22 times higher risk for having respiratory complications and for requiring mechanical ventilation. So that was quite interesting. And then obviously with IL-6 and cytokine storms being an important factor in the etiology of the virus and in the progression of the disease, there are several treatment approaches that are trying to take into consideration and consider IL-6 as a potential target. So some studies have evaluated the use of tocilizumab. So this is a monoclonal antibody, anti-IL-6. It's a humanized IL-6 receptor, and it binds to the receptors, preventing IL-6 from changing cell behavior. So it ultimately decreases inflammation. So this was a small study, and 90.5% of the hospitalized patients recovered after being in hospital for 13.5 days on average. So as far as I know, there are 2 big randomized clinical trials that are evaluating tocilizumab to confirm or refute the evidence for its use for COVID-19. Another approach is the use of dexamethasone, and this is a huge study. And just to short up a bit, because I actually don't have a lot of time left, but this study included more than 6,000 patients, and it resulted on a 30% decrease in the need for mechanical ventilation and in a 20% improvement for patients receiving oxygen. So that was a very positive result, and there are other studies that are looking at dexamethasone to treat COVID-19. And more lately, there has been talk about local corticosteroids like asthma pumps, and the rationale is that it would reduce viral replication more effectively because it targets the lung tissues or the upper respiratory tract tissues. The evidence is still low, 2 in vitro studies and 1 case series, but there are many studies using the use of local corticosteroids for COVID-19. So let's see if we get some good news from these results soon. Let's hope so. So finally, we get to the biological mechanism. All the periodontists know that the link between periodontitis and systemic inflammation has been around for quite a while now. And we know that IL-6 and other mediators are produced locally, but they can spill over to production of inflammatory mediators elsewhere in the body. And the chronic exposure to bacteria or bacterial products induces formation of immune complexes. It also increases formation of expression of inflammatory mediators. Second pathway that we need to consider is the bacterial load in the oral cavity. So every 1 cubic millimeter of oral biofilm has about 100 million bacteria. So oral biofilm can be a reservoir for both oral pathogens and for respiratory pathogens as well. There are 3 main pathways that could explain how oral pathogens reach the lungs. So the first is through aspiration of oral secretions from the oropharynx. The secretions can adhere to lung, epithelium, and facilitate infection. And oral pathogens have actually been identified in lung fluids from patients with lung diseases. The other pathway is the production of enzymes as a result of periodontitis, particular proteases. They are able to alter lung epithelium and bacterial surfaces, facilitating adherence of the pathogens to the respiratory mucosa. And lastly, they can influence, the oral pathogens can modulate adhesion of pathogens to the epithelium in the lungs through the production of cytokines. And something that's worth mentioning, that ICU patients have decreased clearance of oral secretions. So that increases the bacterial load in hospitalized patients, intubated patients, ICU patients, and it increases the risk for pneumonia. And also worth of mention is the fact that some studies suggest that half of COVID-19 related deaths are linked to secondary bacterial infection from underlying chronic conditions. So the oral biofilm or periodontitis pockets could be hidden reservoirs for those pathogens. We could also imagine that gut dysbiosis could contribute to COVID-19 complications because gut dysbiosis has actually been linked to changes in immunity, inflammation, and to respiratory diseases. So new research suggests that pyropathogens can actually contribute to gut dysbiosis because oral bacteria are constantly being swallowed through saliva. So pathogens can reach the guts, and some studies shows that P. gingivalis is able to withstand stomach acids and reach the colon and cause local changes in vitro studies. And normally, oral pathogens cannot really colonize the gut, but under viral infections, it facilitates their colonization. So gut dysbiosis could lead to local alterations, endotoxemia, and systemic inflammation. Endothelial dysfunction is the last of the possible pathways through which periodontitis and COVID-19 could have a shared risk factor. So studies have linked periodontitis to endothelial dysfunction, which is like one of the first steps for atherosclerosis development. And COVID-19 has also been linked to endothelial dysfunction. So it's easy to imagine that periodontitis could play a role through this pathway as well. So here I just summarize all the pathways that we can imagine could influence and have biological foundations. So inflammation in the mouth can lead to aspiration of oral bacteria, can lead to entrance of bacteria to the systemic environment and cause systemic inflammation through the increased production of cytokines and inflammatory mediators, including IL-6. These in turn promote or exaggerate endothelial dysfunction and gut dysbiosis and cause changes in the lungs, facilitating infection. So either through direct or indirect links, periodontitis could potentially increase the risk for respiratory complications in COVID-19 patients. So concluding, we can say that the literature tells us that periodontitis is a risk factor for respiratory diseases, so it could potentially contribute to COVID-19 respiratory complications, as both are related to higher IL-6 levels. The biological links could be systemic inflammation, the bacterial load in the oral cavity, gut dysbiosis, and endothelial dysfunction. So in COVID-19, IL-6 levels seem to be a good predictor for complications and need for mechanical ventilation. So because periodontitis also increases IL-6 levels, we conclude that dental care is very important to control inflammation, where oral hygiene and periodontal treatment can improve health and potentially protect against COVID-19 complications. I would like to thank you for your time. Just bring a quote from Dr. John Laughlin. We are taught to analyze body systems and parts separately and to change one area at a time. Such approach often ignores the interconnectedness of the systems in the human body. So maybe we just need to look at things differently as dentists. Thank you for your time. That was my talk.
Thank you very much for your talk, Carla. Incidentally, now shortly the link will be disconnected. You have to re-link this with the same number and same situation in another few minutes time, because
yes, in another 4 minutes. Yes, to be specific, in another 4 minutes the session will terminate. Please log in with the same login details.
Yes. So thank you, Carla, for this excellent talk. You have given a very good information about the interleukin-6 and periodontal diseases and COVID as well. Incidentally, lungs are very badly affected since the respiratory tract is involved, associated when patients are suffering from chronic pulmonary diseases, even when there's a decreased lung function, when people suffer from pneumonia. Incidentally, the interleukin-6 is also related to respiratory failure as well as in fibrosis, which is taking place. You know, there are 20 times more risk of this particular lung failure in such patients. And as you told, that monoclonal antibody recently for interleukin-6 has been just developing, and that will save a lot of lives. And apart from that, dexamethasone, the corticosteroid, plays a very important role in protecting the person. And of course, the local asthma sprays or pumps can be of great useful to the person. Now, I think we will switch on to the next speaker. Before that, I would like to introduce Dr. Rajiv Chitgupi. Incidentally, he happens to be one of our great speakers, and he happens to be a student of Professor Shankwalkar, who happens to be the father of periodontology in India. Incidentally, he has been an independent researcher in dentistry, an educator in periodontics and implantology. He has been involved in translational research, harnessing knowledge from basic sciences to produce new drugs, devices, and treatment options for the patients. Analyzing the emerging evidence of SARS-CoV-2 and to develop cost-effective innovations and safer dental practice protocols. Incidentally, he is also executive editor of Dental Tribune, which is circulated all over the South Asia. And he's a technical head also for ICPA products. I request Dr. Rajiv Chitgupi to take over and speak. Dr. Rajiv Chitgupi? Yeah.
Thank you, sir. Thank you, Dr. Gururaja Rao, sir. I think we'll have to log out now and we have to log in again.
Yes, yes, yes.
1 minute is left. So thank you for the kind introduction, and it was a wonderful session hearing to Dr. Carla, and amazingly summarized. And I will start once I log in. See you all again.
Yeah.
ಈಗ 3 ಅಂತ ಇದೆಲ್ಲ ಅಲ್ಲಿ ಹೋಗ್ಬೇಕಾ? ನಾನು ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ಬೇಕು. 3 ಅಂತ ಇದೆ.
Rajiv, go ahead.
Yes, sir. I'm sharing my screen.
Yes, sir.
No, you can't touch the screen. There's nothing on the screen. Everything will be done for you. You don't have to do
Can you see
anything.
the screen?
Yes.
Can you see the screen?
Yes, sir. Yes, sir. The screen is visible, sir.
Okay.
Yeah,
Thank
good.
you so much. Welcome back. Thank you for the opportunity. And today I'm here to present my lecture on cytokines, a bridge between periodontal diseases and COVID-19. As we saw just now, there are some risk factors which are common to both periodontal diseases and COVID-19. And even if you look at the pathogenesis, the stages, there are 3 stages in both. In periodontal diseases, we have microorganisms occupying the sulcus, and then they enter the tissues where they cause the diseases, either gingivitis or periodontitis. And then once they spill over and they enter the systemic circulation and they cause various systemic diseases. Same 3 stages can be correlated in COVID-19 as well, where the first stage is localization or colonization of the virus in the upper respiratory tract. And the second stage is the pneumonitis, when it occupies the lower respiratory system. And the third one is when it breaks the cell barrier and enters the circulation and causes various systemic effects based on which organ system predisposition the person may have. So 3 stages here, 3 stages in COVID, and both of them sharing the same common risk factors makes it an interesting correlation. So let me start with periodontitis. This is how I studied periodontitis, periodontal diseases, various hypotheses. Earliest was calling it an infectious disease. of multibacterial origin. So that time we had different hypotheses like non-specific hypothesis, specific plaque hypothesis, and then ecological, where we combined both non-specific and specific. Then came the era of calling this disease as a host response, simple host response that led to the inflammation of the tissues. So it could be either slow inflammation or rapidly occurring inflammation. Accordingly, we classified our diseases. It was an inflammation-driven disease. That was the time. And then we were introduced to the concept of dysbiosis. And then came the concept of linear host response to a dysbiotic microbiome. The microbiome otherwise would be in symbiosis, but when it becomes dysbiotic, that time the host response is even more erratic, leading to a disease condition. And this dysbiosis is because of one keystone pathogen, that is Porphyromonas gingivalis. Earlier concept was Porphyromonas gingivalis itself causes the disease. But in that case, Porphyromonas gingivalis should be able to kill the cell directly, in which case the disease would not spread because the infected cells would immediately die. So the current concept says Porphyromonas gingivalis enters a cell and makes sure that the cell survives for long enough so that other microorganisms can enter that cell, and that's how the disease spreads. So Porphyromonas gingivalis doesn't kill. It actually pampers the cells, and others overtake and cause the destruction. Just like COVID-19, SARS-CoV-2. SARS-CoV-2 doesn't kill people. SARS-CoV-1 killed people because SARS-CoV-1 was a ruthless virus. People used to get symptoms very immediately. That's how they could show the symptoms. It could be easily contained, and those who suffered would die. That's why the virus disappeared very fast, because all those who got infected, most of them died, and that because they showed symptoms very early, the disease could be contained. Whereas here, SARS-CoV-2 is a very lenient virus. It doesn't kill people. It wants to see around the world. So that's why it is keeping people alive. That's why we have mortality rate at very low percentage. So that was dysbiosis Porphyromonas gingivalis, how I connected with SARS-CoV-2, and now the current understanding of the disease. So it's a self-perpetuating state, means never-ending state of prolonged inflammatory response and impaired tissue homeostasis. So this is how we understand periodontitis now. It is not just a periodontal infection. It's a never-ending state of prolonged inflammatory response. So it is non-resolving inflammatory disease as a response to a dysbiotic microbiome. And as I told you, dysbiosis was caused by a keystone pathogen, which was Porphyromonas gingivalis. Earlier we called it as a part of red complex. All right. Now let us see the stages. We have got 4 stages. The first one I have already circled here, initial lesion. This is where the microbial challenge starts and the gingiva develop the initial lesion. And as you can see, the highlighted word, this is characterized by neutrophils, polymorphonuclear cells. So this is the first stage. Then we start responding with our acute inflammatory response, and this leads us to early lesion. So this stage is characterized by macrophages. They could be tissue fixed macrophages, or your tissue may think that it requires more cells, so it may give a call to the vascular space and they may send in some monocytes, which again become macrophages. So this is our second stage. Then third stage is the established lesion. This is our clinical gingivitis. So established lesion is gingivitis. And what are the cells here? Cells are immune cells. Established lesion or gingivitis is characterized by immune cells. What are immune cells? Lymphocytes. T lymphocytes and B lymphocytes. B lymphocytes are the ones which produce antibodies after they go to GALT, gut-associated lymphoid tissue, and they start secreting immunoglobulins, GA, MDE. And in periodontitis, we know that it is IgG which is more important. And then we have got IgG classified into G1, G2, G3, G4, and each one of them has its own polymorphism. And incidentally, IgG2 receptor genotype polymorphism was my dissertation topic in MDS. I did about 153 patients. Okay, so this is our established lesion where the response is immune and inflammatory. This is where we have got maximum inflammatory response, and we have got gingivitis. It is not yet periodontitis. Okay, now comes the crux. See whether this II stage goes into RR stage. II is inflammatory immune response. RR is regulation and resolution phase. So these are two different phases. So what happens in regulation and resolution phase? This is the connecting point between gingivitis and periodontitis. Now look at the top, the funnel. From that funnel, how many risk factors fall down and control the regulation and resolution phase decides whether the person will advance from gingivitis to periodontitis. Very few risk factors, the body achieves homeostasis, then the established lesion does not progress further. It stabilizes there itself and remains, it may remain gingivitis only for many, many years. It will never become periodontitis. But if the inflammatory and immune response is not terminated at the right time, then it progresses to periodontitis, becomes a non-resolving inflammatory state. And then because that funnel is continuously dropping those risk factors, the situation goes on worsening. And that is when these cytokines, which are there, that were trying to protect the body first, then they failed and they perpetuated the inflammatory response. They spill over, enter systemic space, and they cause various other systemic problems. This is how the entire hypothesis is there for periodontal disease and systemic diseases. So this is one interesting article from Nature which shows how, if you look at the, I'll just take a pointer here. If you look at the central diagram, how there was symbiosis earlier and introduction of one keystone pathogen caused dysbiosis. At the same time, this whole dysbiosis, and thanks to this keystone pathogen, the immune surveillance system is shut down. There is nobody to take care of, to look over this. That's why there is dysbiosis and there is entry of the microorganisms into the tissue space. And here you can see there is destruction of bone thanks to the action of osteoclasts. Fine. So if we combine all these things, we come to this equation. For periodontitis to occur, first you need a susceptible host. More the predisposing factor, greater the risk to develop periodontitis. And in this person, three things should happen. There should be microbial dysbiosis. This is the first thing which has happened out of symbiosis. This leads to impaired homeostasis. And then in an effort to control this and its subsequent failure, it leads to prolonged inflammation. So these things keep going in circle, one thing aggravating the other. So this is a never-ending circle and we go on getting continuous destruction of the tissues. So to summarize this, the whole process till now, periodontitis results from the disruption of host microbe homeostasis. So here I am showing the complement system. Complement system is the opsonizing part of innate immunity. So microbes exploit this system, and then there is also an introduction of keystone pathogen. Symbiosis becomes dysbiosis. This dysbiotic microbiota makes use of two separate systems. First is your complement activation, second is toll-like receptors. Both of them are in synergy. As an outcome of this activation, we have got a lot of inflammatory mediators. They are the cytokines, soluble proteins, which act on the cells based on their reaction with the receptors, interaction with the receptors. This recruits more and more inflammatory cells. There is more inflammation, leading to two separate pathways: matrix metalloproteinases, which cause soft tissue destruction, and rank ligand, which causes bone resorption. So overall tissue breakdown. And the products of tissue breakdown further worsen the dysbiosis, cause more and more conversion of symbiotic microbiota into dysbiotic microbiota. And the circle keeps on revolving. This is why we get a never-ending inflammatory process, which is actually a failed inflammatory process. So coming to the cytokines, we have to first divide our immune system into two parts. One is innate immunity, second one is adaptive immunity. Innate immunity is non-specific. Adaptive immunity is specific. It has three characteristics actually: adaptive immunity, specificity, memory, and clonal expansion. It goes on expanding the same kind of cells. This is the first level of classification. Then again, you can divide innate immunity into two parts. One is the polymorphonuclear cells and the macrophages. And adaptive immunity you can divide into cell-mediated and humoral immunity. Okay, so cell-mediated immunity is T cells and humoral immunity is B cells. B cells give rise to immunoglobulins. If you go back to the classical literature, we know that gingivitis is a T cell lesion and periodontitis is a B cell lesion. Okay, so we have to look at them separately. That's how the current vaccine trials are also going on. We have to measure, we have to account for how much T cell responses we have developed and how much neutralizing antibodies we have developed, or specifically IgG, whether they are neutralizing, and if they are neutralizing, survive 3 months, 6 months, how long they offer the protection. So here we have got in innate immunity, we have got separate interleukins, separate cytokines, whereas here we have got separate interleukins. Okay, so this axis is very, very important: Th17 and IL-17. Okay, this is apart from Th1 and Th2. Okay, so if I have to correlate periodontitis right now at this stage with the vaccines, if you develop a good vaccine, we want Th1 response and not Th2 response, because Th2 can give rise to vaccine induced worsening of the disease, whereas Th1 response is very good. This is what most of the trials have elicited. Even Moderna is mostly Th1, even Oxford is mostly Th1. Okay, whereas when we come to innate immunity, the cytokines are different. It is interleukin 1, interleukin 6, and apart from interleukins, if we have to separate, in adaptive immunity we have interferon gamma, and in innate immunity we have tumor necrosis factor alpha. So interferon gamma, interferons are being tried for COVID-19 right now. So this is multiple level correlation between periodontitis and COVID. So coming to osteoimmunology, how periodontal disease causes destruction, you can see here, these are all adaptive immunity responses. Th1 is adaptive immunity, Th17 is adaptive immunity. So this is what is causing osteoclast activation, and that is causing bone resorption. Fine. Now look at this axis, the most important axis of adaptive immunity, Th17 and interleukin 17. So dysbiosis and stimulates antigen presenting cells which secrete interleukin 23. That causes increase in the number of Th17, that causes further increase in the secretion of interleukin 17. So remember the number 17, Th17 and interleukin 17. This axis is critical. It is this axis, Th17, interleukin 17, that causes increased number of matrix metalloproteinases as well as rank ligands, and which further cause destruction of soft tissues as well as hard tissues. So interleukin 17 rankle interaction, interleukin 17 matrix metalloprotein interaction. This interaction causes recruitment of multiple cells and tissue destruction. Okay, so this is how adaptive immunity is causing all the destruction. As long as we control the disease in innate immunity level only, we are safe. We can go up to cell-mediated immunity where we can control it to the level of gingivitis. But if it goes to humoral immunity, then we may not be able to control it and will definitely get periodontitis with tissue destruction. Fine. Okay. So coming back to the same table, we saw Th17, IL-17 axis, which is the most important one in causing the destruction. Now let us focus on innate immunity. Here we have got interleukin 1, interleukin 6, and tumor necrosis factor alpha. This is what is causing the cytokine storm. Why are we getting cytokine storm in COVID-19? Because innate immunity knows that it is non-specific. It is not specific like adaptive immunity. So it has to do its best to remove the pathogen. So in that, because it lacks in the quality, it tries to compensate by increasing the quantity. So it goes on destroying its own tissues to an extent that most of normal tissues, healthy tissues, get destroyed, just like in periodontitis. In order to remove the pathogen from the periodontal tissues, the cytokines destroy the tissue so much that the tooth becomes mobile. Why? because the body wants to remove the tooth and throw it out, so the microbes don't enter the systemic circulation. So the intention is good, but the outcome is bad. That's why right now what we are thinking is, it is not the direct action of the virus that is causing COVID-19. Just like it is not the just the presence of bacteria that is causing periodontitis. There also it is uncontrolled immune response. And in COVID-19 also it is uncontrolled immune response. You have to just control this cytokine storm, which is a feature of innate immunity, which has gone out of the hand. That's why we have got medicines where we are trying to control the hyperimmune response, where we try to control interleukin 1, interleukin 6, but mainly our focus is on interleukin 6. So look at this, going back to the Nature article, central theme of this, how innate immunity is causing all the destruction. The same three molecules I am showing here, interleukin 1 beta, interleukin 6 and tumor necrosis factor alpha. Three characteristics of innate system. If you come outside, we have got other molecules like interleukin 23. This is what causes the secretion of interleukin 17. Here we have got interleukin 17. This is what causes the tissue destruction. Fine. So this is the lymphocyte Th17, and we have got interleukin 17, that is adaptive system, but this is our innate system. So our focus should be to control the hyperimmune response, mainly interleukin 1, 6 and tumor necrosis factor alpha. In these three also, our maximum focus has been on interleukin 6 because it has been the most studied interleukin and the one that is mainly responsible for the cytokine storm. I had two friends of mine who had very high levels of interleukin 6. Normally the range should be less than 10, about 7 or 8. But one of my friends had interleukin 6 levels at 2200, 2200. And another friend of mine had interleukin 6 at 1600. Thank God, thanks to the doctors for great management. Both of them are back from ICU. Both of them are at home doing well. All right. Let us come to COVID now. We saw everything about periodontitis. We made correlations at several points. Now let us come to COVID-19. What happens in severe COVID-19 patients? Okay. So left hand side, SARS-CoV-2 attaches to the ACE2 receptors. Of course, ACE2 is not the only one. We have got basicin, we also have CD26, which leads to the secretion of a lot of cytokines. We can see interleukin 6 here. This leads to change in the number of cells. Macrophages increase, but natural killer cells decrease. End result, cytokine storm. All the innate immunity markers, interleukin 1, interleukin 6, interleukin factor alpha, all of them cause destruction of T cells, destruction of lymphocytes. T cells are also reduced, B cells are also reduced. So lymphopenia is a characteristic of COVID-19. My paper just got published yesterday. It's a preprint. I have come up with the protocol called as ABC protocol. A lot of people are taking some unproven home remedies, okay, and they lose the precious first week of symptoms. That is the golden period where if you control the cytokine storm, the disease will not progress. So ABC protocol is, A stands for air. Check your oxygen saturation, SpO2 with pulse oximeter. If the levels are less than 95 going towards 90, get blood test, simple blood test, CBC, and look for lymphocyte count. Normal count is 20 to 40. If it has reduced, gone below 20, suspected. If it has gone below 10, it must be a severe case. Don't wait for antigen, antibody or PCR test. You may directly go to an imaging center and get your HR CT scan, high resolution CT scan of the chest. This is how I have diagnosed in Indian 2 patients, and both of them were saved from getting into severe disease. So my article has come out of real life experience where I have managed 2 patients till now. So coming to the application part, this is my Facebook post where I had written about antibody cocktails. Antibody cocktails are the future. This was based on this Nature article published in on 5th August. It says that if virus is not having the direct impact, if it is the hyperimmune response that is causing all the problem, immunomodulation should be our goal. So current and future strategies could be control the multiple cytokines. So what are the cytokines I have given here? All 3 innate immune system cytokines. interleukin 1, interleukin 6, and tumor necrosis factor alpha, or control the mother of all cytokines, that is GM-CSF. What is GM-CSF? Granulocyte macrophage colony stimulating factor. So instead of targeting these three separately, just control the top master controller of immune system, everything gets controlled. Okay. If you cannot do these, or even if you do these, you can add one more in improve patients' interferon gamma levels. So interferon levels, interferons are already being tried, especially interferon beta as an inhalation nebulizer, which can control the cytokine storm and also boost the immunity. Okay, so this is how the future strategy is going to be. We are going to have antibody cocktails where the aim is to control COVID-19 cytokine storm. Okay, so this is the proposed cytokine storm inhibition systems. So for anti-interleukin 6 strategy, we have got different molecules here. Okay, so here you can see in between tocilizumab we have. Okay, so we have interleukin 1 anakinra. Anakinra is one of the most in use thing for interleukin 1. Of course, this canakinumab is also one of the most used things for interleukin 1 inhibition. And then the master control, just to control the GM-CSF. Okay, here we have got different drugs. Okay, just like lenzilumab. Then we have got tumor necrosis factor alpha inhibiting drugs. Fine. Now come to one specific molecule, that is interleukin 6, the one that has been studied maximum in periodontal disease. Okay, so interleukin 6 is common to periodontal disease as well as COVID-19, and this is not something new for periodontists. We are already aware of periostat, doxycycline hyclate, where we don't use the antimicrobial dose to kill the bacteria. Doxycycline is a bacteriostatic drug, not a bactericidal drug. So we don't kill the bacteria, we stop their reproduction. So we stop their multiplication. So here what we use is doxycycline not at the antimicrobial dosage, but at sub-antimicrobial dosage. That is 20 milligrams twice daily, adjunct following food cleaning, which may be administered for long term, up to 9 months. Okay, so as you can see, there is a lot of parallel, lot of similarities. Both the disease appear as if they are going parallel to each other. So if the pathogenesis appears similar, interleukins and cytokines appear similar, our strategy could also be similar. So we can introduce doxycycline here also very aggressively. As you can see, one of the most viral posts that went on WhatsApp last week, okay, on 6th August, could gum disease make coronavirus more deadly? People with dental issues have higher levels of immune proteins involved in cytokine storm. So here you can see that the same thing, what works in periodontitis and what works in COVID-19 has already been utilized in other conditions like acne. In the treatment of acne also, they have used sub-antimicrobial dose of doxycycline. And in the same article, JAMA, Journal of American Medical Association article, they say doxycycline's effect on inflammatory acne lesions may be due to its inhibition of interleukin 6, 1, and tumor necrosis factor alpha. Okay, so same principle has been utilized here also. Then another condition, this is for cancer treatment. Okay, because doxycycline attenuates breast cancer related to inflammation by decreasing the plasma lysophosphatidate concentrations and inhibiting NF-κ beta B, means that is the kappa activator of B cells. Okay, and this article says doxycycline decreases the plasma lysophosphatidate concentrations, delayed tumor growth, and decrease the concentrations of several cytokines. Okay, so it's a multiple cytokine inhibitor, which this property can be utilized in COVID-19 as well. These results contribute to a new dimension for understanding the anti-inflammatory effects of tetracyclines, which make them potential candidates for adjuvant therapy of cancers and other inflammatory diseases. So the principle remains the same. We can make use of this. And This is one more. This is in periodontitis. The same thing. Somebody has hypothesized that doxycycline as a potential partner of COVID-19 therapies. Doxycycline, a widely used antibiotic in dermatology with a possible anti-inflammatory action against interleukin-6 in COVID-19. And it is not just a hypothesis right now. They have already been using doxycycline, but in combination with ivermectin. Okay, just like azithromycin was used in combination with hydroxychloroquine, doxycycline has been used in combination with ivermectin. So whatever the controversy, whatever the lack of evidence, but the use of doxycycline is there, and the area of focus is innate immunity, 3 key interleukins, 3 key cytokines, in that also most specifically interleukin 6. Thank you so much. I hope I could give a gist of how I make sense of periodontitis with COVID-19, with some connections with acne as well as cancer. It shows that the platform is common to all of them. Control the immune response, we are good to go. Thank you so much.
Thank you, Dr. Hello?
Hello.
Can you hear me?
Yes. Yes, sir. We can hear you. Yes, sir.
Yeah. Yeah. Thank you very much for a lucid talk, Rajiv Gopi. Incidentally, it has been a very interesting talk. We appreciate your hard work that you have been doing in this research. And incidentally, you have narrated in a very good way the changes that take place in periodontitis, and that could bring about the damage to the periodontal tissues, and so also the damage that occurs in the lung tissue also as a result of COVID-19. All the three remains the same. Incidentally, colonization of the microorganisms or viruses that leads to damage to the lungs tissue by way of pneumonitis and breaking the epithelial barrier, entering into the body stream, and that causes the damage. In fact, I would like to take a salute to Stephen Offenbecker, whose death took place just 3 days ago, 2 years back. And he was the man behind periodontal medicine, who described the invasion of the microorganisms to different parts of the body and cause ailments to not only heart, but also to the reproductive system, to the lungs, as well as in the joints and other places. Incidentally, you have given a very nice narration about Porphyromonas gingivalis, which causes the damage and causes the pampering of the tissue cells, causing them dysbiosis, and that leads to the entry of the other toxic substances into the body, giving rise to all the changes in the host response, right from the polymorphonuclear leukocytes to the macrophages, the lymphocytes as well. Even in gingivitis, there is an increase in the B lymphocyte counts, and in the periodontitis, you will find that there's an increase in the T cell count as well, leading to the production of various interleukins, and of which interleukin 6 has been the talk of the day. Incidentally, we are still combating with these conditions by different ways, by way of vaccines or by way of drugs, and we are still in a question mark which one should be given. Incidentally, you have come out with some of the answers with the relations to interferon, or it could be a drug like periostat, which has been used for periodontal diseases in the management, and which has also been used in the treatment for acne and as well as in treatment of cancer. So I wish that our talk has been very informative, and I hope that everyone has enjoyed. And I request if any questions are there, please, you're welcome to ask. Please tell your name and then give your questions, please, to the speakers. Any questions, please?
So this is Dr. Smita. I would like to thank both the speakers. It was excellent, a way of putting things across. Now, just going into the deeper aspects, I was thinking whether vaccines will work or should we concentrate on immunomodulators? There is nothing like a particular target in COVID-19 where it can work. So I was also doing the review of the same, and I was not able to come up with a constructive answer how a vaccine can work in a situation where it is targeting multiple cells and cytostorm is there, cytokine storm. So something like immunomodulation will be a better thing, I felt. Any answers for this, sir?
Yeah,
Yeah.
Kala.
Yeah, please.
Yeah, Kala and Rajiv both. Yeah.
I can't say at the moment. I don't think I'm informed enough about vaccines and how they work and how they could work in this case. I don't feel prepared to give you my opinion because I honestly don't have one at the moment, to be honest.
Okay. So the thing is, both of them have different areas of work. That is,
Yes.
our immunomodulators will have work on anybody who has already got infected.
Yes.
There we need to separate it. So these are antidotes, because SARS-CoV-2 binds to the receptor, ACE2 receptor, 10 to 12 times stronger than SARS-CoV-1. So you need a strong separator that can, dislodge it from there.
Correct.
So this is where we need very strong antibodies that can separate. And in vaccines, it is for healthy people who are not infected yet. So you give them, but we need vaccines which will also train your body to generate your own antibodies. Because if we just give passive antibodies and they go and cover the receptor binding domain, RBD, now what happens is B cells are always under selection pressure.
Correct.
If selection pressure is good, your body will generate antibodies which are specifically neutralizing for receptor binding domain. Now, if your receptor binding domain is already covered, your body under the selection pressure will create some other antibodies which are non-binding.
It will bring more complication.
Yeah, we don't need passive ones. We need antibodies. We need immunotherapies which also train your body to generate neutralizing antibodies. And coming
my
to
question
immunomodulation,
is, if the vaccines are released, are you willing to take?
Yeah, of course. I'll be the first person to take. I'll bite in black based on what results have come. So I want to see the results. For example, we have been tracking Moderna, Oxford right from the day one. Like I can tell you the results of phase 1, phase 2, everything. Whereas if suddenly somebody comes and the Chinese virus, Chinese vaccine, if somebody says, I don't know how much whether I'll be volunteering myself.
Okay, Rajiv.
Moderna is better.
Can we give some chance
And
to some others?
sir, actually in the saliva, there are two factors.
Yeah.
Yes, sir. There are two things. One is ACE2 and also the role of purine. Purine is again one more receptor, which is enzyme receptor, which COVID-19 is binding to. And that's why there is infection through oropharynx and through oral cavity, especially on the tongue. So this aspect also has to be explored.
Yeah, we have got only three minutes.
Yes, sir.
We have got only 3 minutes to end. And I request if anyone has got questions, please put it up in our chat box, in our messenger group. You can be getting the answers. Okay. Thank you very much. I think I was running short of time, and I request Smita to present the e-certificates to both of the participants, both of the speakers, and kindly oblige. Smita. Yeah.
Yes, sir. So I would like to present the e-certificates to Dr. Rajiv Titkupi, sir, as well as Dr. Carlos C. Pontes. Can you see this?
Yes.
Yes, lovely.
We are very much obliged, and this is the brainchild of our Dr. Gururaja, sir, and hope you have liked the presented certificates, and we also be obliged for you people to be in constant touch in future also for further such e-meetings. Thank you. Thanks a ton.
Yeah.
Thank you very much.
You're welcome, ma'am.
Oh, caramel.
So May I thank
Dr. Rajeev sir, I have a question. Sir, what is the role of chlorhexidine in regular dental practice which we can use? The role of chlorhexidine.
Yeah, chlorhexidine. Yeah. Yeah. You want me to tell about chlorhexidine?
Yes, sir. A little bit.
Yeah. So in the month of February, there was a perception that chlorhexidine doesn't work on the virus. So that prompted me to look into the literature, because SARS-CoV-2 is the weakest virus. You break the lipid envelope, it dies. And chlorhexidine is the best mouthwash. How can it not work on SARS-CoV-2? And when I checked the evidence, I saw that the old experiments had used only 0.02% of chlorhexidine, and our mouthwash is 0.2%. And in April, we got a publication in Lancet.
That's terrible. She's got to control herself.
The virus at the concentration of 0.05.
Yeah, we're getting off now.
And in May, and in the month of May, we got Korean University publication which said chlorhexidine can reduce the viral load in the mouth for 2 hours. And for 2 decades, we know that chlorhexidine is the only mouthwash that has got substantivity, which keeps on releasing in the saliva. Povidone iodine has 0 substantivity. Hydrogen peroxide has got 0 substantivity. You take them and you rinse, they will kill the existing viruses. But within 2 minutes, new virus enters from salivary gland. Who is going to take care of that? That's why you need mouthwashes with substantivity. I think I covered everything in last 60 seconds.
Thank you. Thank you.
Thank you so much. Thank you so much, sir.
Thank you.
Thank you. Thank you.
Wonderful.